I'm Dr. Lorraine Dugoff from the University of Pennsylvania.
I'm Dr. Liona Poon from the Chinese University of Hong Kong.
We're in Singapore at the 2019 Annual International Society for Prenatal Diagnosis meeting, and we have the pleasure and honor of interviewing Dr. Diana Bianchi today. Dr. Bianchi is director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development and head of the Prenatal Genomics and Therapy section for the Medical Genetics branch at NHGRI. Dr. Bianchi has made tremendous contributions to the field of reproductive genetics. She's a pioneer in the field of non-invasive prenatal diagnosis, initially through the NIFTY trial. She's the editor of the journal Prenatal Diagnosis. She's a winner of multiple awards, a generous mentor, and a great source of inspiration. So we'll start with some questions regarding cell-free DNA. So the first question is, do you think that the technology for cell-free DNA screening for fetal aneuploidy will ever be improved enough for this considered to be a diagnostic test?
So it's very important to realize that it's currently a screening test, and I believe that it will remain a screening test, really an outstanding screening test. I think the technology will continue to improve. Recently, paired end sequencing has been added to some of the testing regimens. The testing will probably become less expensive and more accessible around the world, but you can't change the biology. So what we're looking at is the cell-free DNA from the placenta, and we're looking at cell-free DNA from the mother. Now, there have been some technical improvements to distinguish the cell-free fetal DNA from the cell-free maternal DNA, but you will always have the fact that the fetal DNA is really placental DNA. So perhaps we will ultimately have some way of distinguishing between the placental DNA and the actual fetus DNA, but I think for now we need to think of it as a very advanced screen.
What is your view on the use of cell-free DNA screening for cancer?
So this is a great example of unexpected downstream findings. The testing was developed for prenatal applications, and yet it's really shown that it's also a liquid biopsy for some cases of cancer. I think it's very important to find out exactly what the downstream implications are of women who have either non-reportable findings or multiple aneuploidies that are suggestive of cancer. The difficulty in the United States so far has been who's going to pay for the workup, who's going to allow the follow-up. I know that I've been involved in some of these cases as part of our lab's research, and our patients have had a very difficult time, for example, getting insurance to pay for a full-body MRI when it's not known to be clinically indicated yet. So there's a great need to know what is the natural history of these cases, how sensitive is the test for detecting cancer, are some of these cases really due to fibroids, and our hope is to create an evidence base so that we can inform subsequent clinical care for women who have these unusual findings on non-invasive prenatal screening. So we're starting a new study now at the NIH Clinical Center called the Identify study, which is aimed at following up women who potentially have cancer, in which we'll be able to give them the complete workup for free. We'll be able to travel them within the United States and provide lodging for them. And we can enroll them into the study during pregnancy or up to a year after delivery, and then provide appropriate follow-up. So I guess I'm in favor of doing the follow-up and finding out whether the test is accurate for detecting cancer.
So while we're waiting for the results of your study, how would you approach the evaluation for a woman with a positive cell-free DNA result that's concerning for a malignancy?
That's a great question. You know, again, it's not really known what is cost effective, but at a minimum, they should have a specific physical exam. There's suggestion from data in the literature that a full body MRI might be indicated, but again, there might be a cost implication. certainly a hematopoietic profile, a chemistry profile, taking a very full body kind of clinical exam. Some people suggest referring to an oncologist, but many oncologists are not aware that this type of prenatal testing can actually suggest cancer.
You have published data regarding the effectiveness of cell-free DNA testing for sex chromosome aneuploidies. What are some of the challenges associated with cell-free DNA screening for sex chromosome aneuploidy?
Well, I think the first challenge is that we've never tested for sex chromosome aneuploidies, and many of the sex chromosome aneuploidies are clinically silent at birth. So it's very unusual to find an anomaly in a little boy who has Klinefelter syndrome. So generally the diagnosis is made late unless there has been prenatal diagnosis. So it's kind of a new phenomenon with NIPS, NIPT, that we're able to make these suggested diagnoses. And when there's a Y chromosome present, it is more accurate because clearly a mother, in most cases, doesn't have a Y chromosome. So it's clear that there is a Y, that the fetus will be male, but there may be excess X chromosome sequence, which would suggest Klinefelter syndrome. The real difficulty is in the X anomalies, so either 45X or 47 triple X. And I think it's important for providers to realize that the positive predictive values for particularly monosomy X is much lower than it is for Down syndrome. And I have gotten many calls and asking for information about what to do when the NIPT results show monosomy X. And I think many people don't realize that a significant percentage of these cases are really due to maternal 45X, either that the mother is a 45X mosaic or that there's somatic mosaicism as a result of maternal age. And that is a normal phenomenon. But we recently did just sort of an informal meta-analysis of the clinical studies that are available, and the positive predictive value when averaged over all of those studies was only 26% for monosomy X. So I'm usually quite reassuring when I talk to couples that it's less likely that this is a fetal result, that it is more likely that it's a maternal result. And I think another thing is that the test results have shown us that there are many more pregnant women who have Turner syndrome mosaicism than I previously thought possible. And these women are getting pregnant without any assisted reproductive technology.
In our lifetime, do you think that we can achieve non-invasive prenatal diagnosis for all chromosome and genetic conditions?
I think that we've made significant progress. I don't think we'll, even with invasive technology, at least in my lifetime, we're going to be able to diagnose everything. I mean, that makes the assumption that you're going to see everything in the DNA sequence, and you're not necessarily looking at epigenetics and other aspects of either transcription or the proteins. So I would focus on the fact that we have made tremendous progress, and particularly in developing treatments for prenatally diagnosed conditions. But I think it's unrealistic to expect that we'll be able to prenatally diagnose everything. And I think most parents, at least in my counseling, they want some sort of reassurance that the baby's going to be normal or typical. And I always say to them as a parent that eventually you have to give the car keys to the child. And you just can't control everything, and there are going to be unexpected circumstances. So we'll do the best to help them have a healthy pregnancy and have a healthy child, but you can never assure perfection. The children don't come with a certificate.
To date, the focus of prenatal diagnosis and screening has been fetal aneuploidy. Is this the most appropriate goal?
Yeah, so aneuploidy writ large is such a small percentage of things that complicate birth. And problems like preterm delivery, preeclampsia, these are the kind of the grand obstetrical issues, and we're not as good. In fact, not knowing when a baby is going to deliver prematurely is a huge problem with enormous clinical significance. So prenatal diagnosis of aneuploidy has a long historical component to it, and the Down syndrome community, I think rightly so, is concerned that there's this unusual focus on Down syndrome when there's been so much progress in how people with Down syndrome have been integrated into the community. I was just at the Trisomy 21 Research Society meetings in Barcelona this past June, so just a few months ago, and they had young adults who have Down syndrome working at the conference, working at the registration desk. The conference education was provided, the conference entertainment was provided by people who have Down syndrome. So they had a play with actors who all had Down syndrome. The musicians providing the music in the play all had Down syndrome. There was a video presentation by a young man who talked about his life with Down syndrome. I moderated a panel on clinical research for people with Down syndrome. We had adults with Down syndrome talking about their perspective on being a research subject. It was transformative. So, the prenatal testing for Down syndrome started back in the 80s. Actually, amniocentesis was being tested in the 70s, but the screening part was in the 80s. And I think things were different then. I think we really need to turn some of our focus towards these bigger problems that affect people worldwide.
Congratulations on receiving the ISPD Pioneer Award. During your acceptance speech, you acknowledged the fact that there are a number of challenges associated with the rapid technological advances in reproductive genetics. Can you elaborate on some of these challenges and how we might address them?
Yeah, it's been this field has been fascinating because the technology has really advanced so rapidly. I mean, year by year, there are these tremendous advances, and the healthcare providers on the front line cannot possibly catch up. I mean, we come to the prenatal diagnosis meetings every year, and even we learn about all of these new things that have happened in the past year. So there's a huge challenge in terms of how do you educate the actual people on the front lines, and they may not all be physicians. They could be nurses, they could be people who don't have expertise in obstetrics, so family practitioners in the United States. They could be midwives, they could be genetic counselors. I think the genetic counselors are very savvy. But the typical primary care provider doesn't have access to this very timely continuing education. So we have to solve that problem. And there have been different approaches. I know in the UK, they've had this massive education campaign to teach people about genomics, and that's been very successful. We've been less successful in the United States.
How can we best integrate genomics into clinical care?
Well, I think part of it is, again, the education issue, but having both directed a medical school genetics course and led a genetics service at an academic medical hospital, there are two big problems. One is many medical schools do not want to devote more time to genetics education, even in medical school. I mean, you could argue that the high school students are getting more education than the medical students are getting, at least in the United States. The second thing is, at the hospital level, there's still this perception that genetics is really just all about babies with birth defects, and people don't realize that genetics and genomics is part of care for everybody. So many things affect families as opposed to a child. Complications in surgery, for example, could be due to an underlying genetic problem, and there just has to be a rethinking of the role of genomics. I don't have the answers, but we need to address it soon.
There's significant disparities between people who can afford sophisticated testing and those who cannot. So how can we approach this both in the United States and in low and middle income countries?
Yeah, so I'm quite troubled by the disparities in healthcare, and particularly in the United States. There are people who can pay for these sophisticated technologies, and there are people who can't. I mean, there actually are a number of states within the United States where the Medicaid system, the public insurance system, is paying for example, non-invasive prenatal screening in high-risk cases. But then you have wealthy, low-risk individuals who can afford to pay for the testing on their own, and they do because there's this great popularity, for example, of these gender reveal parties. And people want to know the gender of the baby as soon as possible, and so they will pay for non-invasive prenatal screening. I think that this is a small problem in terms of the larger problem in terms of how to provide health care for all people in the United States, and that's currently being discussed in a very political way. But the goal ultimately should be to make the testing affordable enough so that it could be offered as part of public insurance for all people in the United States. And similarly, globally, although problems like treatment of malaria, treatment of other infectious diseases, are killing lots of children, we should hope to develop low-cost tests that would allow people who want the testing to take advantage of it. And I think that will happen in our lifetime. There's so much innovation, for example, now in Africa, where people develop leapfrogging technologies, and it's quite inspirational. So that should be our goal, and hopefully as part of our international society we'll be able to be more inclusive of places like Africa.
What advances do you foresee in the field of prenatal diagnosis over the next 5 to 10 years?
So again, I think that there will be technical advances in the rapidity of the testing, the specificity of the testing, examining ways to distinguish the cell-free fetal or placental DNA from the cell-free maternal DNA, examining the importance of the fetal fraction. We've heard a lot about low fetal fraction. We haven't heard so much about high fetal fraction. But in a sense, the cell-free DNA testing is like a liquid biopsy of the placenta. And the placenta really tells us a lot about the health of the mother, the health of the pregnancy. So we should be able to get more information there. I think that looking at gene expression and the transcriptome and both single cell sequencing as well as the transcriptome of the amniotic fluid tells us really important information about what is happening in real time during each stage of the pregnancy. And I think there's a lot more to learn there.
What do you see as the biggest challenge or challenges to future research in prenatal diagnosis?
Well, as a former academician, I think funding is a major issue. For many people working in different countries, getting adequate grants to do their research is challenging, and you spend a lot of time writing grants, and not all of them are successful because, again, this is a relatively small area of medicine, and it's not considered to be an emerging public health crisis. So funding is a challenge. So if you don't get it from a government organization, you either have the opportunity to look at a foundation or industry. And personally, I've had successful interactions with industry, but even now, industry-sponsored research comes under additional scrutiny, as it should. But funding is one big challenge. Another is, in terms of a career, balancing clinical work with research work. And everyone comes up with their own equation, but it's quite difficult, particularly in the United States, where your chairman or chairwoman wants you to earn your salary, and so if you're not getting a grant, then you have to do more clinical care, and that's a self-defeating proposition. And in fact, the whole career for a clinician scientist really needs, I think, a re-examination, because in some sense we're asking people to fail. If they're not immediately successful in getting grants, then they'll have to do more clinical work. If they do more clinical work, they'll never have the time to do more grants.
What advice can you give to all researchers who are applying for grants right now?
Yeah, I think it, very important to be persistent. One of the reasons why I took my current position was so that I could help to shape the science, also be able to give more money to young investigators so that we would be able to fund people in the next generation and give them that important start in their career. When I was at Tufts, I led the Natalie Zucker Scholars Program, in which we gave out approximately $30,000 US per year to, first of all, it was only for women applicants, and they had to be early in their career, from the postdoctoral fellowship phase up until the assistant professor phase. And in general, we would give out 6 grants per year, $5,000, and they were judged on merit and whether or not the support would have a positive impact on their career. We recently just did an analysis of the return on investment, and incredibly high percentage of these women went on to get additional funding and have success. And it really showed the fact that just as little as $5,000 US and the confidence that came with it of achieving a grant successfully had an enormous impact on the pipeline. So that was very gratifying. So my advice is try to start with these small grants, get preliminary data, and then as you're applying for the larger grants, you have to be prepared for not receiving them. But there's no such thing as failure. That's one of my big messages. You learn something from the peer review, and you just have to take your ego out of it, which is, it's hard for everybody, but it's especially hard for women.
What inspired you to pursue the field of prenatal genetics? Were there any events that set your path to prenatal genetics, or how did it evolve?
There were a few events. I'm the only person in my family in science or medicine. I was especially inspired by a high school teacher who just was a great biology teacher, and at my high school, which was an all-female high school, by the way, excellent science program. In our senior year, we had to do a thesis, and so I was assigned to the cytogenetics laboratory at a hospital in New York City. And there I learned how to do a karyotype, and I was looking at the chromosomes of women who were heroin addicts. And not only did I learn how to do a karyotype, but I met a number of female pediatricians. So that was very influential, both in terms of the clinical work as well as the science. And that convinced me that I wanted to be a doctor. So by the time I went to college, I knew I wanted to be a doctor. And in medical school, my first year of medical school, I had done research in college. I arrived in medical school really knowing quite a lot about cytogenetics, and I met the Herzenbergs, who they were professors of genetics and immunology, and they had a son with Down syndrome. And when they met me, they said, well, we want you to help to develop a non-invasive prenatal test for Down syndrome, because we didn't know when our son Michael was born that he was going to have Down syndrome. And Lee Herzenberg was only 29 at the time when she delivered him, so she was not at high risk. So that was very inspirational, although I didn't meet Michael until many years later. That was the challenge per se that put me on my career path. I think what's remarkable is that I've stayed on it, really, that it kind of led me in a very straight path, but there have been such interesting findings along the way. And I think that, as I always say in my laboratory, the data are the data, that don't be so fixed on that straight path, because then you will ignore these other very interesting things, such as the whole microchimerism story, that fetal cells can stay in maternal organs and repair maternal organs, or that the secondary genomic findings as a result of NIPT or NIPS are actually as interesting as the screening result. So those were the two.
If you could travel back in time, what advice would you give yourself on finishing medical school?
So I think hopefully things are different now, but I think that women in particular have an issue with confidence, and I did take things personally. You know, if I didn't get a grant, or this was later than medical school, but if I didn't get a grant, or if a paper was rejected, you know, you wonder, are you really cut out for this? And I think the advice I would give myself is just be patient. It will all make sense. It's actually like a giant puzzle, and you know what your interests are, so just stay with it and develop that thick skin, and everything is going to be all right in the end. I mean, I think a good example is I couldn't decide. I loved pediatrics, I loved obstetrics, and it was somewhat random which one I chose. And then many years later, I would say, you know, my research is all in prenatal diagnosis. I should have gone into obstetrics and gynecology. Now there's so many more women in obstetrics and gynecology. When I was in medical school, I had a bad experience. It was very, very surgically oriented on my OBGYN rotation, and it was very old boys surgical network, and that turned me off. And for years I would say, oh, I should have gone into OBGYN. But it all works out in the end. My current job, it's actually an advantage to have knowledge of pediatrics and knowledge of OBGYN, and also knowledge of rehabilitation medicine. So there is a happy ending, and I think most people do have a happy ending if they follow their passions.
Thank you, Dr. Bianchi, for agreeing to be interviewed today. It's been our pleasure, and we have learned a lot through our questions. So do look out on our ISPD website for the expert interview series, and in the past year we have interviewed 3 experts in the field of prenatal diagnosis and screening. The first one was with Professor Nicolaides from London, the second one was with Professor Dennis Lowe from Hong Kong, and the recent one was with Professor Louise Wilkins-Hock. And I think in the next year we'll be interviewing more experts, so do watch this space. Thank you.